Mohs is not automatically necessary for every skin cancer. Its value rises when the microscopic edge is hard to predict or especially consequential.
This explainer was written and edited by Dr. Thomas Hocker, a triple board-certified, Harvard and Mayo Clinic-trained dermatologist, Mohs surgeon, and dermatopathologist.
Okay, hold on. Let's just cut right to the chase for anyone facing a diagnosis right now. Does every single skin cancer actually need Mohs?
No, it doesn't. And honestly, that is exactly where we need to start. A lot of low-risk tumors, they're treated perfectly well with standard excision or other approaches. It should literally never be an automatic assumption. So let's dive into the actual difference between these two paths. Standard excision removes the visible tumor with a planned rim of normal-appearing skin around it. Then a pathologist looks at representative sections from that piece. And hey, that's a really solid, sound treatment for many skin cancers. But Mohs surgery, it's different. It removes a thin layer with a complete mapped margin assessment. Mohs isn't just more surgery or some super aggressive excision. It's fundamentally about getting more information during the surgery itself. Let's walk through how that real-time info actually works in practice. Step 1. The surgeon removes a thin layer of tissue. Step 2. They map out exactly where it came from. Step 3. The peripheral and deep margins are processed and examined en face under a microscope right while you wait. And Step 4. If any tumor remains, the next layer is taken only from that specific involved spot. It's basically a mapped feedback loop, and it just continues until those margins are absolutely clear.
But wait, is Mohs always better, or does it just kind of sound more advanced? I mean, if I'm the patient, shouldn't I just demand the high-tech option just to be safe?
When Mohs usually adds value, see, that is exactly the trap we want to avoid. You really shouldn't just ask if it sounds more advanced. The much better question is whether mapped margins will actually change your safety or your reconstructive options.
A really massive factor here is high-stakes anatomy. We're talking about places like the eyelid, the nose, lip, ear, hand, foot, or the genital area. In functionally constrained sites like these, just a few millimeters can completely change the reconstructive repair. So complete margin assessment becomes incredibly valuable because preserving every possible millimeter of normal tissue is absolutely critical.
Now consider the concept of recurrent or, poorly defined cancer. If a tumor has come back after a previous treatment, it might extend in these really irregular ways right through scarred tissue. Or if a lesion has indistinct borders, well, what the naked eye sees, the visible edge, that might not equal the true extent of the tumor hiding beneath the surface, which we call the microscopic edge.
And the underlying pathology matters immensely too. Certain aggressive or mixed features tell us that the extension is going to be a lot less predictable. So if you look at your biopsy report and you spot complex terms, things like infiltrative, micronodular, morphiform, sclerosing, or basosquamous, or even perineural, which just means nerve involvement, these all suggest a higher risk. A partial biopsy can so easily miss an aggressive component in a mixed tumor, which makes the thorough mapping of Mohs highly valuable.
We also have to look at the patient's broader health context. Take cutaneous squamous cell carcinoma, or CSCC. It actually behaves more aggressively with certain depths, rapid growth, or particularly in patients dealing with immune suppression. These broader systemic risk factors, they can move a tumor right into a pathway where complete margin control isn't just a nice option, it's truly necessary for proper clearance.
Mid-video reset. When excision is enough. Okay, let's do a quick reset here. We've established that Mohs offers complete mapped margin control. And that is incredible for high-risk, unpredictable, or really tissue-sensitive situations. But the unresolved question is still hanging out there. How do we know when not to use it? The absolutely crucial point here is that a good decision also identifies when standard excision, or just a lower burden option, is exactly the right fit.
Wait, let me stop you right there. So if a cancer is on my face, does that location automatically mean I have to get Mohs?
Location matters absolutely. But diagnosis, size, borders, recurrence, overall health, and repair consequences, they all still belong in the decision. Check out this fascinating piece of evidence. In a 10-year randomized clinical trial looking specifically at facial basal cell carcinoma, there was a clear long-term recurrence advantage using Mohs, but for recurrent tumors. For primary tumors, the difference favoring Mohs over standard excision actually wasn't statistically significant over that entire 10-year trial.
And that's exactly why lower burden options aren't a compromise when they actually fit the tumor.
Small, primary, well-defined basal cell carcinomas on the trunk or extremities, those can be treated perfectly well with standard excision. Selected superficial BCCs, they might just need topical therapy. And most localized invasive melanomas actually follow a wide excision pathway rather than routine Mohs. The point is, medically appropriate alternatives definitely exist, and they for sure should be used when indicated.
Okay, but what about the aesthetics of it all? Will Mohs always create a smaller scar? Because I'm pretty sure that's what a lot of patients naturally assume.
Not always, actually. See, Mohs can preserve uninvolved tissue by directing that additional removal only where it's absolutely needed, but it still has to follow the cancer. The final wound depends completely on the true microscopic extent of the tumor. Plus, your scar's final appearance, that also depends heavily on your specific anatomy, the exact type of repair chosen, your own individual healing process, and, well, just time.
All right, one more practical question for you. If my initial biopsy came back with a negative margin, doesn't that mean the cancer's already gone and I can just skip any further surgery?
Not necessarily. A biopsy is primarily just a diagnostic sample. Sure, it might remove the visible lesion, giving you a negative margin on that specific, tiny piece of tissue, but it may not represent the full, microscopic boundary of the entire tumor. And that is exactly why proper treatment matching, based on the full clinical picture, is so absolutely critical, even if you just got a reassuring biopsy report.
The Patient Toolkit, clarifying your decision. So, how are you supposed to navigate all of this at your next appointment? Well, this toolkit will help you clarify your decision right alongside your clinician. Here are the literal exact questions you should bring to your appointment. Ask your clinician, what exactly makes this tumor lower or higher risk? Is the border clinically clear to the eye? How will the peripheral and deep margins actually be assessed during treatment? And if Mohs is not chosen, what is the medically reasonable alternative and why? Asking these questions ensures your treatment perfectly matches your own specific risk profile.
Dr. Hocker created Skin Trust to provide free, evidence-based dermatology education and help patients and clinicians make clearer decisions together.
We invite you to read the full evidence-based article at Skin Trust, and most importantly, discuss your individual decisions directly with your treating clinician. Now, if Mohs is planned for you, your best next step is to check out our explainer on the next big question, what to expect on the day of Mohs surgery. Empower yourself with the right information. After all, are you going to let a simple visual guess dictate your treatment, or will you advocate for the complete microscopic picture?